Hello, I'm Nikhil Munshi from Dana-Farber Cancer Institute at the Harvard Medical School. And we are discussing today how can we predict responses to CAR T cell therapies, all various constructs such as ide-cel and other products. Now, it's important for any treatment that can we predict the response will occur or not, and how long is the second question. Now, before we go into the scientific points of whether we can predict or not, one thing is very clear that CAR T cells are extremely effective. So if you look at the responses we observe with CAR T cells, they are in the tune of 73 to 100%. There were 3 different studies, each one having majority of the patients responding, and a reasonable proportion of patients, anywhere between 33 to 86% patients achieving complete response. So responses are reasonably universal, everybody responds. The CRs are a little bit less. In a couple of studies, it is 1/3 of the patient. In CARTITUDE-1, with small number of patients to start, was 80+%. And so the question then eventually would end up being, can we predict who is going to get CR or not, because everybody responds. That brings about what are the various things we can look for to predict the response. Now, the bottom line is that there is no accurately predictive value currently available. So everybody will end up getting treated with the CAR T cell products, whichever product becomes available, that we will know that most of them are going to respond, because the studies I mentioned, the median number of cycles patients had received varied anywhere from 5 to 6 to 7. And so these are heavily pretreated patient population, and even then responses are 75 to 100%. And so there is really no clear predictive method. However, as with anything else, we are trying to look for various features. So one of the things that has come up, and it's of significant importance, is the expansion of the CAR T cells. Data published for ide-cel previously and presented for both orva-cel and cilta-cel, the other 2 products that are in advanced stage of development, all of them have shown that there is some relationship with the expansion of CAR T cells and the response. So for example, ide-cel, the peak expansion happens on day 11. And similar kinetics are for other products as well. However, by itself, when it expands is not predictive. However, the level of expansion is. And so if you look at one of the studies, higher the expansion, the greater chance of responding. It's not 1-to-1, but there is a correlation. And the other parameters studied are called the exposure, the AUC of 0 to 28 days. During those 28 days, what is the exposure to CAR T cells? And higher the exposure, higher the response. And there is also some connection with the high AUC with the high dose. So higher dose in ide-cel study leads to higher responses. And I think that we have to probably keep in mind that will also translate for other studies, that the dose may matter and may be predictive. And so patients who get the dose of 300 milligram per meter square versus those who get higher dose level, the responses are different. At 300 dose, the overall response rate in ide-cel study was 69%. For 450 million cells infused dose, the overall response rate was 82%. So there was an increase. And at 150, the lowest dose, there were only 4 patients, so it may or may not be as accurate, but was 50%. And so there is some gradient about relationship to the dose. And those may translate into higher AUC for exposure, and we have to keep that in mind. This higher AUC leads to higher responses. It also has some relationship with the depth of response and also some relationship with longer PFS. So we have to keep this in mind. The next number is that persistence. Do CAR T cell persist, and longer persistence, does it lead to higher level of response and or differences in outcome based on that? Now, data about this is less clear. In ide-cel study, for example, at 12 months, 36% patients, those who were measured, and there were small numbers of patients where it was measured, 36% were persistently positive. At 6 months, it was 59%. But in large majority, the numbers do decrease over time. And whether the longer persistence has any association with better outcome PFS is not yet clear, partly because of lack of data. But I think that's one of the things that we will have to keep in mind. It is also clear that there have been patients who do not have persistence of the CAR T cells and they still remain in remission. So there is a lot of kinetics and dynamics ongoing that will need to be determined. But another thing to keep in mind for future is persistence of CAR T cells. The third thing is there is an ongoing concept about having anti-CAR T cells immune responses being developed. And there is, in fact, even lesser data on this subject at the present time. But something to keep in mind that some of the CAR product may not be fully human, may have murin and other components against which immune response can happen. And even in fully human, there's a possibility of some other immune reactions that can happen. And we have to keep it in mind that this immune responses against CAR T cell may have some relation that needs to be explored in regards to response and duration of response, etc. Another marker that is being discussed is soluble BCMA. Now, BCMA produced by myeloma cell can be cleaved and its soluble component can be detected in circulation. Now, soluble BCMA does not prevent or decrease the CAR T cell efficacy. So that's a very important endpoint. In some bispecifics, the soluble BCMA does interact, but for CAR T cells, so far data does not suggest such interaction. However, soluble BCMA by itself is a good marker of the disease. So it is very high before CAR T cell infusion. Following infusion, it declines very clearly, and by 3 months, it goes to, in a large proportion of patients, to undetectable level, indicating response to the treatment. And then in some patients, the BCMA rebounds and it decreases, and we have to keep in mind that it may be marker of disease, not as much marker of response and or resistance to the therapy. So I think there are a number of interesting investigations which are ongoing that will help define what can be utilized to predict response to CAR T cells. Currently, I would suggest all patients are good candidates to undergo CAR T cell response, and greater data will inform us about who are the better candidate and would get better responses. Thank you very much.